welcome to a new episode of IBD Essentials. Together with my co-host Florian Rieder, we are sitting here again, and we were just discussing recently about the relevance of antifibrotic therapies, and Florian is the lead investigator of the so-called Stenova trial, and I think we will really discuss a little bit about it today. We are really happy that our podcasts are so well attended. So if you like us, you really can like us. If you would like to have new topics, if you would like to comment, please do so. We are very happy to address your important points and questions. And Florian, perhaps before we start talking about the Stenova trial, I think we should go a little bit to the background. Fibrosis, you're the so-called Mr. Fibrosis. Perhaps you can give us a little bit of the background that is behind it, like classification of strictures, stenosis, measurement, how to develop and set up this type of clinical trial, because you're the lead investigator and everybody wants to listen to you and wants to learn from you.
Yeah, Axel, thank you so much for having me back, and thanks for your kind introduction. So I'm very excited that we are reporting Stenova today, and Stenova is set to address an important clinical problem, which is stricturing disease. And more than half of patients with Crohn's disease develop clinical symptoms of obstruction in their lifetime. And Crohn's disease is a progressive disease, so the accumulation of this extracellular matrix and scar buildup happens over many, many years, and we have not been able to effectively prevent that with anti-inflammatory therapy. So despite the emergence of novel drug classes and us getting better and better in achieving mucosal healing, the rate of stricturing disease has been stable, and in fact, the rate of surgeries for intestinal obstruction in Crohn's disease is increasing. So it is not only a stable unmet medical need, in fact, it may get worse over time. And so we set out to address this problem of stricturing Crohn's disease. And I was very enthusiastic about it. As you know, we spent a lot of time doing it. But the challenge was we could not really measure what a stricture is and how to improve. So the first step we took is from a global group, which is called the STAR Consortium, Stenosis Therapy and Anti-Fibrosis Research Consortium, to develop endpoints for clinical trials that we hoped at that time would find regulator acceptance, and in fact did find regulator acceptance. So we developed a patient-reported outcome tool called the SPRO, the stricture PRO, and then imaging tools. And for Stenova of relevance is MR enterography. So we defined what strictures are, how to measure them, what constitutes improvement, and can we measure improvement. And this was a lot of work, in fact, being done before Stenova even started.
Can you just share how long it was taking approximately in years before you were ready to then start the trial?
Yeah, so it sounds like a long time. It took 7 years to develop this from scratch, but to put it into perspective, at the beginning of this, we did not even know what are strictures and how are strictures defined. There was no consensus in the field. And so considering all of this, 7 years is actually light speed to come to an early development clinical program.
No, it's really light speed. And I think a lot of us have been involved, especially in these consensus procedures. And I think you really nicely gathered very important people to get this started and get this developed. And ultimately, probably also a drug appeared, and we will talk about the drug pretty soon. And there was someone who wanted to spend money and get this drug investigated for this probably very difficult trial. We know there are a lot of trials failing, especially in IBD. A lot of trials are failing, very nice phase 1 data or even phase 2 data. But when they move to phase 3, they are not that convincing and they are stopped. And there are other compounds out, and we were discussing earlier, fibrosis is always correlated with inflammation, so a lot of targets are just focused on the anti-inflammatory effects, but I think we know that this goes together. What are your thoughts and your opinion?
Yeah, so I think it's a very good point, Axel. There are two components to fibrosis. There's an inflammation component, and inflammation is important for initiating. So there has never been an area in Crohn's disease and ulcerative colitis, for that matter, where fibrosis has been reported within the GI tract if it has not been involved by inflammation. So it is for sure an initiator and likely perpetuator. There's a correlation between the degree of inflammation and the degree of fibrosis. The more inflammation, the more fibrosis. But over the years, we learned even if you successfully treat inflammation, the levels of pro-fibrotic factors remains high, and the tissue damage continues to accumulate. So it's inflammation dependent and inflammation independent mechanism. And the first phase in trying to prevent strictures was we tried to get better and better in treating inflammation. We have new drug classes, vedolizumab, P19s, JAK inhibitors, now recently TL1As in development. But it looks like we are not effectively able to prevent stricturing disease. So we need to focus on inflammation independent mechanism.
So if we walk now a little bit further and look at the mechanism of fibrosis, you mentioned pro-fibrotic factors, so there may be anti-fibrotic factors. I think from medical school and pathophysiology, we learned a lot about extracellular matrix factors. When I was younger, I was also active in the field. So how do you choose the right target for medical treatment, and how do you get then the right compound to interact? And probably you will really fill us in the mechanism which is targeting one of the key pro-fibrotic factors, TGF-beta, and the receptor.
Yeah, so there's a big dilemma in the field of tissue remodeling and antifibrotics, because the inflammation pathways and the remodeling pathways are often unbalanced, meaning if you treat inflammation, you don't treat remodeling, and if you treat remodeling, you may actually in some instances worsen inflammation. And one example for this is TGF-beta, a transforming growth factor beta, is a chief pro-fibrotic cytokine across all organs. It's elevated in fibrotic diseases. If you inhibit it, you can prevent fibrosis of the lung, the liver, the heart, the skin. In animal models, in clinical studies, there's promising signals that if you block TGF-beta, you can block fibrosis. But the problem was the systemic inhibition, because TGF-beta also has a role in immunoregulation. And if you inhibit immunoregulation, you may make inflammation worse. Immunoregulation is important for cancer, as it's a potential cancer risk. And then specific to TGF-beta, it's important for heart development. So if you inhibit TGF-beta, you may have negative effects on heart valves. And so there was a lot of enthusiasm in blocking TGF-beta either with antibodies or with inhibiting signaling with small molecules. The signaling molecule to the TGF-beta receptor 1 is called ALK-5, and TGF-beta receptor 1 is the key receptors for signaling of TGF-beta. And systemically, it has not panned out, largely because of safety concerns. And so for that reason, a molecule was developed called Ontunisertib that has high exposure of the mucosa of the intestine, but the moment it hits the circulation, it has a first-pass metabolism in the liver, and it gets converted into metabolites, a few of the major metabolites, and the metabolites are inactive. So the concentrations of the drug in the circulations are very low to non-detectable. The metabolites are inactive, so you can have locally high concentrations in the intestine, but no systemic exposure. And another comparison for this, which our audience is probably familiar with, is budesonide, where you give local release steroids, high concentration in mucosa, low concentration in circulation. But this, in fact, enabled then Stenova into testing this in humans.
Yeah, I was reminded about the first path effect of budesonide, which we know for a long, long time. But it's fantastic to get these important ideas. So there was probably a lot preclinical, in vitro models, animal models, then the first patients. Ultimately, are there side effects? I assume the patients in the trial have been measured, especially with heart aspects. They will probably undergo several things. You need to tell us.
Mm-hmm. Yeah, so the clinical program started preclinical first. So in animal models, this compound showed antifibrotic effects. But what was surprising already then is it also showed anti-inflammatory effects. So we were concerned that if you inhibit TGF-beta in the intestinal mucosa, you may create this imbalance in immunoregulation, in effect exacerbate inflammation, but we had signals already early that the opposite is the case. And then it went to a phase 1 study where healthy volunteers get single doses with increasing concentrations, and then multiple doses with increasing concentrations for safety reasons. And it turned out that systemically the concentrations were very, very low. The drug arrived in the mucosa, and there were really no concerning safety signals in phase 1 healthy volunteers. And then this led to testing it in patients in a phase 2A study called Stenova, where we used patients with terminal ileal stricture in Crohn's disease in reach of endoscopy. They had to have at least one stricture in reach of endoscopy. And stricture was defined as wall thickness, luminal narrowing, and then either presence of pre-stricture dilation or not being able to pass the endoscope, but they had to have wall thickness and luminal narrowing on endoscopy. The stricture symptoms had to be tolerable based on the stricture PRO greater or equal to 2, but as tolerable that likely they don't have to undergo balloon dilation or surgery over the duration of the trial, which was 12 weeks. And the patients had to obviously have Crohn's disease. They were not allowed to have internal penetrating disease, abscess, fistula associated with it, no stomas, no shortcut, or certain other medications like JAK inhibitors, for instance, were not permitted due to, at this time, unclear interactions.
There are some questions with the selection of patients, because you mentioned there were also possibilities of having several strictures, but they all needed to be in the reach of the endoscope. So when you have like multiple strictures, the first need to be passable by the endoscope, and to reach them, this was the case there?
It's a very good question. So only the distal stricture would need to be in reach of endoscopy. Passability was not required. So about 3/4 of the strictures, in fact, were not passable with the endoscope at inclusion. But across the board, when looking all small bowel strictures in Crohn's disease, about 80% or so are in the terminal ileum within reach of endoscopy, and only have one stricture. And then the rest have 2, 3 are located more proximal.
And then co-medication, you mentioned co-medication was not really allowed, but so were the patients in active disease, or were they really non-active patients with fibrotic strictures? And was there really no IBD-specific co-medication, nothing that could be continued?
Yes, so also a very good question. So I can talk a bit about the design of Stenova. So a total of 103 patients were randomized 1:1:1, high dose Ontunisertib, low dose Ontunisertib or placebo over a duration of 12 weeks. And the drug was given on top of standard of care. And standard of care in this case was 75% of the patients were on biologic, about 40% of them on anti-IL-23 or anti-IL-12/23, 30% on anti-TNF, and the rest was vedolizumab. So most medications were permitted except JAK inhibitors. And the duration of the trial was 12 weeks. And then at the beginning there was imaging, at the end there was imaging, there was symptom assessment in between, and then the beginning endoscopy and at the end endoscopy. The population of the trial was long-standing disease, so 17 years of disease duration, 85% of the patients prior exposed to biologics. They all obviously had small bowel disease and small bowel strictures. About 50% of them had prior surgery, and then 75% were on concomitant biologics during the duration of the trial. So it's a very advanced patient population. The inflammation severity was mild to moderate, so the SCSCD was 7.4. Mean SCSCD was 7.4. Fecal calc protected in the 200s and CRP normal. So it was a fibrotic population with low inflammatory activity.
But just listening to your description, it's probably one of the most advanced patient populations ever. Probably not that much of activity because they have now good drugs and are well controlled. But everything you mentioned is probably the worst patient population I can remember. Duration of the disease, surgery, pre-treatment. It's really a heavy population.
Yes, so for drug development programs in the IBD space, it would almost be a death signal usually, because these advanced patients don't respond to therapy anymore, and usually they go to surgery.
But now, after so much discussing about the design and everything, I think everyone is getting excited. What are the results? Because everyone is looking for the gold medal here. And please tell us.
Yeah, so the primary endpoint was safety tolerability. So the trial completion rate was very high. 89% of the patients completed the trial. Adverse events were balanced across all groups, placebo, low dose, and high dose. And I can point out two adverse events. One life-threatening adverse event in the placebo group was a patient that developed obstruction due to adhesions from prior urologic surgery that spontaneously resolved, was considered unrelated to the medication. And then in the high-dose Ontunisertib group, there was one death reported. There was a 75-year-old male that had type 2 diabetes, hypertension, hypercholesterolemia, developed a stroke, was discharged from the hospital after the stroke, came back later with failure to thrive, and then passed away, but was considered unrelated to the Data Safety Monitoring Board. So in other words, the drug was safe, well tolerated, and no concerning safety signals. It was actually a big finding because it's a first-in-class type medication. And then secondary endpoints were pharmacokinetics. So what does the body do to the drug? And pharmacodynamics. What does the drug do to the body? And pharmacokinetics were as expected and comparable to the phase 1. Very low systemic exposure of the drug. You found the metabolite in the circulation in concentrations expected and dose dependent. So the lower dose had lower levels of the metabolite, the higher dose had higher levels of the metabolite. And the concentrations of the drug at the level of the mucosa were high. So it's a locally acting TGF-beta blocking medications. What was really interesting then were the exploratory endpoints. So when looking at symptom endpoints, using the symptom PRO tool that was developed by the STAR consortium, there was a rapid placebo response in the patients already after 4 weeks, which then there was no further improvement with the study drug, and there was a floor effect reported. So one of the learnings, since we know that the instrument properties actually function well, which we understood through the validation work we did in the consortium, likely the patients did not have severe enough symptoms to see a difference with this instrument, and we need to understand placebo response better. But the symptoms in all patients, in fact, got better in a robust manner. When looking at the endoscopy endpoints, and I want to mention again 17 years disease duration, small bowel disease, 85% exposed to biologics. The SCSCD response rate defined as a decline in SCSCD compared to baseline greater or equal to 50%, close to 30% received endoscopic response in this patient population, which was 18% improvement over placebo, which in a population like this has not been seen, in fact, even with anti-inflammatory medication. An endoscopic remission rate was about 20% in the high-dose Ontunisertib group. Endoscopic remission was defined as SCSCD less or equal to 4, and no subscore of greater than 1. When looking at passability, which is important for stricturing disease, I mentioned about 70% of the patients not passable stricture endoscopy at baseline. In the placebo group, close to 7% of the patients were passable after week 12. In the high dose group, more than 30% were passable after week 12. So the lumen gets wider and the stricture can be passed again. And then the last endpoint, exploratory endpoint, was imaging, which is what we had established as a future co-primary. So symptom and imaging likely would be the regulatory endpoints in the future. We found improvement in all parameters, stricture parameters on imaging. There was about 2% 2 centimeter shortening of the stricture at week 12 in placebo compared to both doses of Ontunisertib. There was 2 millimeter less pre-stricture dilation after 12 weeks, and there was also a reduction in wall thickness over placebo with the treatment. And this was only after 12 weeks. So I can tell you, going into this trial, I did not expect too much because it's a short trial, 12 weeks. I would have anticipated we need at least 24 weeks to see a difference, a highly refractory population. And you see improvement rates we have not seen before, even with existing anti-inflammatories. And to wrap up the exploratory endpoints, there was not only improvement in the luminal narrowing subscore of the SCACD, but there was improvement across all components of the SCACD, affected surface, size of ulcer, and ulcerated surface area. So we may not only have an antifibrotic, we may also have an anti-inflammatory for small bowel Crohn's disease.
This is really amazing, and you reminded us in the end that all these endpoints were achieved at 12 weeks.
Yes.
So at least in my opinion, and I think for the majority of us, fibrosis is something which seems to be a long-term process. And you just mentioned on a side step that you didn't expect that it was working so quick. So I would assume there would be much better results if you look at week 24 or 52, because the formation and rebuilding of the fibrosis will probably take some time. Did you have by any chance some impression on the side or time effects? So in the animal models or all the work you did before and the company did before, do we know something about the speed of onset and then ultimately how long it will take?
Yes, so it's also a good question. So I can talk about, perhaps as an example, stricture length, which is a likely endpoint for later registration studies. In the placebo group, stricture length in fact worsened over 12 weeks, and then the treatment groups kept the stricture length stable, which then led to this 2 centimeter difference at week 12. Open label extension data will be reported separately, but suggests that if you give the drug longer, the effect will in fact get even better than what we saw after only 12 weeks. And this went into the design of the phase 2b that will come, where the induction endpoint will be later at 24 weeks. And then there will also be a full maintenance arm in a treat-through design. And this is one change, so make the induction endpoint later. And the second change is, given the good safety profile, the anti-inflammatory effect, and the large safety window given the PK and NPD observations, there's also room for a higher dose. We may even see further improvement compared to what we've seen in the phase 2a. So overall, in my opinion, still early days, but in my opinion, for first-in-class, first indication, early development study, very exciting data.
Yeah, and what I really liked is anti-inflammatory and anti-fibrotic effects. And one final point I would like to ask you. You mentioned the very high persistence, so like 88 or 89% of the patients finished the end of the trial. This, for me, includes that there has been probably no real side effects. Was there a difference in the three groups? So was it overall the same in the different groups? And what else was, you mentioned the two issues with side effects. Were there other reasons to discontinue the trial?
Yeah, so it's a very important point in early development. So at the moment, from these 103 patients, and 2/3 of them were on the drug, there was no concerning safety signals, and all adverse events were balanced across the treatment groups. The patients had extensive monitoring, particularly regarding heart, because of the concerns on heart valve issues. So they got cardiac echo, they got EKGs. There were no signals with the drugs. There were no dose-dependent finding with the drug. So I think there's a lot of confidence to move this forward in development.
Wonderful, Florian. I think this was really exciting to share the news of the paper which just appeared today. So it's really wonderful. Thank you so much. And we will share the details, or we already shared the details of the paper on our website. And hopefully this is also exciting for you, and I think we will hear much more about antifibrotic agents, and not only in Crohn's disease but perhaps also in ulcerative colitis, and there will be more of this. So stay tuned, like us if you really had fun with this wonderful discussion. Thank you, Florian.
Thank you for having me.